When food is ingested, it travels along the digestive tract, where it is broken down into its component nutrients in order to be absorbed into the bloodstream. One such nutrient is glucose, a simple sugar. Glucose gets absorbed by the intestines and then enters the bloodstream. It travels through the circulation to all body cells. Once absorbed into the bloodstream, glucose circulates, causing the blood sugar level to rise. An increased level of blood sugar sends a signal to the pancreatic beta cells, which respond by secreting the hormone insulin into the circulation. Insulin is necessary for glucose to reach and be used by several important target tissues throughout the body. These include the liver, muscle, and adipose tissue. Insulin is necessary to keep blood glucose levels stable in the body. Glucose enters the cell through a process called facilitated diffusion.
Diabetes refers to a group of conditions characterized by a high level of blood glucose, commonly referred to as blood sugar. Too much sugar in the blood can cause serious, sometimes life-threatening health problems. There are two types of chronic diabetic conditions: type 1 diabetes and type 2 diabetes. Pregnant women may acquire a transient form of the disease called gestational diabetes, which usually resolves after the birth of the baby. Prediabetes is when the blood sugar level is at the borderline, higher than normal, but lower than in diabetics. Prediabetes may or may not progress to diabetes. During food digestion, carbohydrates, or carbs, break down into glucose, which is carried by the bloodstream to various organs of the body. Insulin is a hormone produced by beta cells of the pancreas and is necessary for glucose intake by target cells. In healthy people, beta cells of the pancreas produce insulin. Insulin binds to its receptors on target cells and induce glucose intake. In type 1 diabetes, beta cells of the pancreas are destroyed by the immune system by mistake. The reason why this happens is unclear, but genetic factors are believed to play a major role. Insulin production is reduced. Less insulin binds to its receptor on target cells. Less glucose is taken into the cells. More glucose stays in the blood. Type 1 is characterized by early onset. Symptoms commonly start suddenly and before the age of 20. Type 1 diabetes is normally managed with insulin injection. Type 1 diabetics are therefore insulin dependent. In type 2 diabetes, the pancreas produces enough insulin, but something goes wrong either with receptor binding or insulin signaling inside the target cells. The cells are not responsive to insulin and therefore cannot import glucose. Glucose stays in the blood. In other words, type 2 diabetics are insulin resistant. Here again, genetic factors predispose susceptibility to the disease, but it is believed that lifestyle plays a very important role in type 2. Typically, obesity, inactive lifestyle, and unhealthy diet are associated with higher risk of type 2 diabetes. Type 2 is characterized by adult onset. Symptoms usually appear gradually and start after the age of 30. Type 2 diabetes accounts for about 80 to 90% of all diabetics. Management focuses on weight loss and includes a low-carb diet.
A1C test is a blood test used to diagnose diabetes and monitor the progress of a treatment plan. The test result reflects the average blood sugar levels in the past 3 months. A1C is a type of glycated hemoglobin, a hemoglobin that is bound to glucose. Hemoglobin is the major protein of red blood cells. A1C forms as a result of interaction between red blood cells and sugar in the blood. The higher the blood glucose levels, the more glucose binds to hemoglobin, the greater the amount of A1C. The A1C blood test reports the percentage of hemoglobin that is bound to glucose. Once a hemoglobin is glycated, it remains that way in the blood until the red blood cell carrying it is removed from the circulation. Because the average lifespan of a red blood cell is 3 to 4 months, A1C measurement represents the status of blood glucose for the past 3 months or so. A normal blood glucose level corresponds to an A1C result of less than 5.7%. An A1C level higher than 6.5% indicates diabetes. Between 5.7 and 6.5% is pre-diabetes. An estimated average glucose level, EAG, measured in concentration units, milligrams per deciliter or millimoles per liter, can be calculated and often reported in addition to the A1C percentage. EAG helps patients link A1C to the numbers they obtain at home using a blood sugar measuring device. A1C is an important tool for managing diabetes. For most diabetics, the goal is to bring A1C level down to 7% or less. However, patients' age and other health conditions must be taken into account when setting goals. In general, younger patients who don't often experience severe low glucose, known as hypoglycemia, need lower goals to avoid diabetes complications in the many years ahead. Older patients or those having frequent low glucose episodes may have a higher goal. It is important to note that several factors can affect the accuracy of A1C test result, in which case, unless corrections can be made, A1C cannot be used to assess blood glucose levels. For example, people with blood disorders such as sickle cell disease, thalassemia, or hemolytic anemia may have a lower than expected A1C because their red blood cells have a shorter lifespan. Iron deficiency anemia, on the other hand, is associated with falsely high A1C measurements. Some people of African, Mediterranean, or Southeast Asian descent may have uncommon forms of hemoglobin that produce falsely high or low results. Certain kidney and liver diseases may affect the turnover rate of red blood cells and give rise to inaccurate A1C readings. Finally, recent blood loss or transfusion will also skew the test results.
Hypoglycemic drugs are medications used to lower blood glucose in type 2 diabetic patients. Dietary glucose absorbed from the intestine passes by the liver before entering the general circulation. The liver controls glucose output to the blood by converting excess glucose into glycogen for storage. During a fast, glycogen is converted back to glucose to be released to the blood. 2 major pancreatic hormones are involved, insulin and glucagon. Insulin is secreted in response to high blood glucose levels, such as after a meal. Insulin enables body tissues to uptake glucose, thus removing it from the bloodstream. Insulin also stimulates conversion of glucose into glycogen and fatty acids. On the other hand, low blood glucose levels induce glucagon release. Glucagon acts on the liver to promote conversion of glycogen back to glucose, as well as de novo glucose synthesis. While type 1 diabetes is caused by a low insulin production and can be effectively managed with insulin injections, treatment of type 2 diabetes is more complex. By definition, type 2 diabetic patients have a normal insulin level, but their tissues are not responsive to insulin. However, with time, some patients may also start losing insulin production. Hypoglycemic medications may promote insulin production, increase insulin responsiveness, decrease hepatic glucose output, reduce dietary glucose absorption, or increase glucose excretion in urine. Sulfonylureas inhibit the ATP-dependent potassium channel in pancreatic beta cells, basically hijacking the glucose-induced insulin secretion pathway. The result is an increased insulin release that occurs independently of blood glucose concentrations. Major side effects include hypoglycemia and weight gain. Some agents are associated with higher mortality for cardiovascular diseases. Meglitinides act in the same pathway as sulfonylureas, but via a different receptor binding site. They are shorter acting and produce a greater decrease in post-meal glucose, but otherwise have similar clinical efficacy and side effect profile as sulfonylureas. DPP-4 inhibitors inhibit the enzyme DPP-4 that inactivates the incretin hormones GIP and GLP-1. These hormones are released within minutes of food intake and act to stimulate insulin secretion and inhibit glucagon secretion. Their action is, however, short-lived because DPP-4 degrades them almost immediately. By inhibiting the DPP-4 enzyme, DPP-4 inhibitors prolong the action of incretin hormones, thereby lowering blood glucose. A notable adverse effect is a slightly increased risk for acute pancreatitis. GLP-1 receptor agonists mimic the action of GLP-1, but are much longer acting. They also slow down gastric emptying and reduce hunger, thereby lowering blood glucose levels as well as facilitating weight loss. They are most often administered subcutaneously due to poor oral bioavailability. Side effects are mainly gastrointestinal, although rarer but more serious adverse effects may occur. Thiazolidinediones are insulin sensitizers. They promote insulin-dependent glucose uptake in muscles and fat. These drugs activate the nuclear receptor PPAR-gamma that controls transcription of genes involved in glucose and lipid metabolism. Major adverse effects include peripheral edema, hypoglycemia, worsened heart failure, increased risk for cardiovascular events, and bone fracture. Metformin works by reducing hepatic glucose output and, to a smaller degree, increasing glucose uptake by peripheral tissues. Common side effects are gastrointestinal. Rarely, metformin can cause lactic acidosis, which can be fatal, and is therefore contraindicated in patients at risk of acidemia. Alpha-glucosidase inhibitors inhibit alpha-glucosidase enzymes that digest carbohydrates in the small intestine, thereby reducing dietary glucose absorption. Their major effect is a decrease in post-meal glucose. Side effects are mainly gastrointestinal. SGLT2 inhibitors inhibit the sodium-glucose co-transporter responsible for glucose reabsorption in the kidney. Reduced glucose reabsorption means more glucose is excreted in urine and less is left in the blood. Major side effects include urogenital infections, ketoacidosis, and renal impairment.
Are you a fan of